Good evening, everyone, and welcome to the SAB's second Fellows Corner presentation. Thank you for joining. Before we begin, I just have brief instructions for our audience. Everyone is able to submit questions throughout tonight's presentation. Simply submit them within the control panel or the question or chat feature. Dr. Kashishin is our moderator this evening, and he will moderate the Q&A after the presentation. I'll hand it over to Dr. Kashishin at this time to introduce our speaker, and he sits on the SAB's Education and Program Committee. Thank you.
Thank you, Emily. Thank you for the introduction. Hello, everyone. I would like to welcome everyone to today's second Fellows Corner webinar. We have an excellent speaker today. She is a second-year fellow, Dr. Harumi Tokashiki at Chicago Medical School, Rosalind Franklin University. And I know that she wants to pursue critical care fellowship after this. So welcome, Dr. Tokashiki. It is my pleasure to moderate this webinar. And today we're going to talk about acute chylothorax, road to diagnosing low-grade follicular lymphoma. So you have a mic, you can start.
Thank you, Dr. Kashishin. Thank you to the Education and Program Committee for this initiative of giving us the spotlight to the fellows, and not only fellows, also residents. So I can start, let me see. So just to share the spotlight given me today, I wanted to share my program. It's a 2-year pulmonary disease fellowship program. We train here in the Greater Chicago area, in the urban, suburban area, the VA, and also in downtown. And we also work with Dr. Bawadam in Aurora, Kenosha. Okay, so I wanted to share this case. Just briefly for the agenda and the learning objective, I'm going to present the case. We're going to review the pathophysiology of non-traumatic chylothorax, the diagnostic and therapeutic medical and surgical strategies in the management on non-traumatic chylothorax, the role of conservative versus aggressive management, and to highlight the rare onset of follicular lymphoma. So to present the case, we received an 83-year-old female who arrived to the ED with 1 week of progressive symptoms of dyspnea on exertion, dry cough, unintentional weight loss. She didn't endorse any significant past medical history, no surgical or trauma history. And unfortunately, she has not been seen by any PCP in the last 5 years. Physical exam was remarkable for mild tachypnea. She was sitting 93% at room air. And for the physical exam on the lungs, we were able to appreciate bilateral, but predominantly on the right, dullness to percussion, decreased tactile fremitus, diminished breath sounds overall, and the posterolateral chest auscultation. And she had a significant palpable axillary lymph node. So this is the initial X-ray that we significantly noted the bilateral effusion, predominantly on the right side. Let me see. Oh, I see the cursor. So after that chest X-ray, the ED team ordered a CT angiogram just to rule out PE, and this is what we see on the mediastinal and lung windows. So as we noticed on the X-ray, there was bilateral effusion, predominantly on the right side, moderate to large effusion. And after reviewing this CT angio, which was negative for pulmonary embolism, we proceed to the collection of the pleural fluid by a thoracentesis. This is the pleural fluid analysis. We get a predominant lymphocyte effusion with this chemistry. Total proteins were 4.5, albumin 2.6, LDH 122, triglycerides on 296, and the serum at the same date, the protein was 6.4, LDH 238, albumin 2.7, and by Light's criteria, it met criteria for an exudate with elevated triglycerides. And the cytology, we had some atypical cells reported, but negative for malignant cells. So after this analysis of the thoracentesis, we got at the conclusion this was a chylothorax. And the patient became more in respiratory distress. So we pursued chest tube placement. So this is an X-ray on the left side after the chest tube placement with completely re-expansion of the lung on the right side, but persistent on the left. And through the hospitalization course of the patient, we got a cumulative drainage of 5 liters in 6 days. On average, daily drainage or output of the chest tube was less than 1 liter. So while waiting for a more workup and definitive diagnosis of this chylothorax, we had a multidisciplinary meeting, and we decided for the least invasive approach. As we noted on the physical exam, the patient had a axillary lymph node. So that lymph node was biopsied, and the immunohistochemical stains were compatible with low-grade follicular lymphoma. These are the specific markers that are congruent with low follicular lymphoma with a low proliferation with a Ki-67 that was low. And the CD21 positive expanded follicular dendritic cells, which are pathognomonic for follicular lymphoma. So the follow-up for this patient after the chest tube was removed, at the same time, oncology was on board right after that biopsy results, and the patient was started on rituximab, allopurinol, low-fat, high-protein diet. And this is the CT 3 months follow-up as an outpatient. Okay. So we have the lung windows and the mediastinal windows. We see persistence of the right-sided effusion and decrease on the left-sided effusion. But at this time, when we saw the patient as in the clinic, she didn't lose any respiratory distress, no tachypnea or anything. So subsequent thoracentesis was not pursued at this time. She also endorses compliance to the diet that was prescribed, and she was compliant to the medications, and she was also compliant to the follow-ups with oncology. So we wanted to share this case of chylothorax because the prevalence of chylothorax in all pleural effusions is around 3%, and that traumatic chylothorax outnumbers the causes of chylothorax, but the non-traumatic are even more rare. So just to briefly go through the pleural physiology, we have a normal volume of pleural fluid. It's around 0.3 mL per kilo body mass. And the function of this pleural fluid is to guarantee that close apposition of the visceral and the parietal membranes that guarantees that frictionless sliding of the lung during breathing, during inspiration and expiration. So the lymphatic provides a drainage of the pleural cavity. I'm not able to see it, but we see the parietal lymphatic stoma that drainage to the parietal pleura. So all the pleural space fluid will drain to through the parietal pleural lymphatic system. So any accumulation between the pleural cavity of chyle and without known trauma or injury to the thoracic duct, we'll call it non-traumatic chylothorax. So what is chyle? Chyle is lymph and chylomicrons which are absorbed from the GI tract, composed by lipids, electrolyte, proteins, and it's important to know that it also contains lymphocytes. So the small and medium chain triglycerides are broken into free fatty acids by the intestinal lipases and absorbed into the portal circulation. The long chain triglycerides and phospholipids, cholesterol form the chylomicrons, and these are transported by the lymphatic circulation via thoracic duct. So around 2.4 liters of chyle is transported from the intestines to the systemic circulation. And on the right side, you can see the anatomy of the lymphatic drainage on the lungs. So we see the thoracic duct that below the thoracic 5 and 6 is on the right side and then crosses the midline to the left side at that level and drain it into the subclavian and the internal jugular vein. And in the figure below, we can see the stomas that drain from the parietal pleura. Okay, so The pleural fluid categorize your chylothorax versus pseudo-chylothorax. So how do we differentiate this? It's really important if you see the milky liquid from the thoracentesis that you always need to order triglycerides and cholesterol. So to define chylothorax, we will need a triglycerides level more than 110 and cholesterol levels less than 200. And that will be helpful to distinguish from pseudo-chylothorax, and that will be also for utility for the etiology. So this is an algorithm proposed by Dr. Khalil. So if you have a clinical suspicion of chylothorax, we'll have to send the fluid sample for cholesterol and triglyceride levels. If we already have a triglyceride levels more than, so we use milligrams per deciliters, more than 110, we have a chylothorax that is confirmed with less of 200 of cholesterol. And if we have more than 200 of cholesterol, it will be a pseudo-chylothorax. If we are in between, in the gray area, we will have to pursue lipoprotein electrophoresis so we can detect chylomicrons. And that will help us distinguish between chylothorax or pseudo-chylothorax. So as I was mentioning before, the causes of chylothorax, most of them are traumatic, especially involving the posterior mediastinum, for example, esophagectomy or thoracic injuries. And the other etiology, if it's non-traumatic chylothorax, is neoplasm. Almost around 75% is due to lymphoma or metastatic carcinoma. And this is explained by the lymphatic leakage can be a consequence of direct tumoral invasion of the thoracic duct or increased intralymphatic pressure, secondary to an extrinsic compression of the lymphatics. And pseudo-chylothorax, the etiology is going to be tuberculosis or rheumatoid arthritis. So for imaging, part of the diagnosis part and workup for chylothorax, the gold standard is a conventional lymphangiography. However, this is an invasive diagnostic test. We have limited availability and the risks of exposure to ionizing radiation are also to be cautious. And magnetic resonance imaging are the most preferred by non-enhancing MR lymphangiography and the dynamic contrast enhanced magnetic resonance lymphangiography. The dynamic contrast enhanced magnetic resonance is an invasive study, and the non-enhanced is a non-invasive study. Let me show you some pictures. So here we have a patient with a chylothorax. Sorry, let's see the arrow. It was a 35-year-old man with non-Hodgkin lymphoma. We see the coronal views, and the asterisk shows highlighted the hyperintensity, that chylothorax. And with the arrows, we can see the mediastinal mass. And on the B figure, we can see the thoracic ducts that can have multiple areas at multiple levels of stenosis, most likely caused by the infiltration of the cancer. And on figure C, we can see that by a consequence of this obstruction, you can create collateral lymphatic drainage. And the arrows are pointing the axillary lymphatic ducts. Okay. So the utility of the imaging study and the adequate imaging study, like magnetic resonance lymphangiography, will help us distinguish more like rare etiologies and what is causing this obstruction in the thoracic duct. So we will be able to distinguish if there's an interrupted thoracic duct, or is there a dilation, or if there's lymphangiectasis, if there's any aplasia or congenital malformations of a thoracic duct, and we will be able to see levels of the stenosis. And these images, it will be crucial for the next step if we need, or if the patient is candidate for any surgery. I just wanted to highlight that primary lymphatic dysfunction, like we see patients with LAM, that in 40% of the patients in the course of the disease, they can present with chylothorax. So the magnetic resonance lymphangiography is of utility to see that primary lymphatic dysfunction. So for treatment, we have the conservative option. We opt for conservative if the patient is already established with the etiology of the non-traumatic chylothorax. So for example, in our case, we had a positive biopsy of the axillary lymph node and the patient started on rituximab. But because that's the main treatment, treating the etiology. And the conservative management is auxiliary to that. So the dietary measures, the goal of this dietary measure is to decrease the flow given to the lymphatic drainage. So we give low fatty diet or medium chain triglycerides consistent with the nutrition because we can decrease the flow of the lymph. We opt for medium chain triglycerides because these are directly drained to the portal circulation. If the patients fail to this type of nutrition, the option will be total parenteral nutrition. For the pharmacological options, we have somatostatin and the synthetic analogs like octreotide. And the mechanism of utility of these pharmacological agents is reducing the splanchnic blood flow. And this is a novel agent, midodrine, which also is the hypothesis is acts as vasoconstricting this splanchnic circulation. For the interventional options, unfortunately, if the patients are like any patient that is symptomatic with chylothorax, like the case we presented, or respiratory distress or requiring oxygen, we have to provide drainage, but the drainage or the chest tube that it's going to be placed for chylothorax cannot exceed more than 2 weeks because we can start having severe malnutrition and immunodeficiencies caused by the constant drainage of the chyle. So if the patients have not responded to the treatment of the etiology of the chylothorax, for example, chemotherapy, radiation, and they have failed conservative management, the first option is chemical pleurodesis. But to decide for chemical pleurodesis, we need to secure that the visceral and the peritoneal pleural achieve apposition. So there was a case series that reported 100% success on lymphoma-related chylothorax, and these 19 patients failed chemotherapy and radiation, but this was only a case series of 19 patients. And the pleuroperitoneal shunt, which it will be an invasive procedure, and they will drain the chyle directly to the peritoneal. This is useful just for a palliative measure because it can increase risk of infections, dysfunctions of the shunt. The thoracic duct embolization, most of the time done by IR, it has 73.8% of success on the first attempt. And surgery, which can do through thoracoscopic or VATS, it will be the thoracic duct ligation. But to pursue these all interventional steps, we'll have to go through the proper imaging study so they can localize the level of the stenosis or the level of the leakage of the thoracic duct. So it has shown 90% of successful rate, but 1 out of 9 patients may have to undergo multiple procedures. And up to 38% have had complication rates. So this proposed algorithm I wanted to share, it was published in 2022 by Dr. Khalil. So if we faced non-traumatic chylothorax and we have a malignant etiology, we should refer to a relevant cancer or multidisciplinary team. If there's a specific cancer treatment available for this patient, we will pursue that and start it without any delays. And if there's a resolution of the chylothorax, that will be completed the management. But if there's no resolution of the chylothorax, we'll have to go through more imaging testing and identify if there's an active leakage or if there's any specific stenosis. So after we've gone through the lymphangiography, if the patient, if we are able to identify anything that we can correct through any invasive procedure, if the patient is suitable for this intervention, we will offer that intervention and monitor for the resolution of the chylothorax. If there's no resolution of the chylothorax, we should opt and establish other interventions, like, for example, diet, pharmacologic agents, chemical pyrolysis, and perioperatal shunting. If there's a non-malignant etiology, we should offer a specific treatment if it's available. So going back to the case, I wanted to highlight the etiology of the low-grade follicular lymphoma, because this is has a good prognosis, but most of the time he has an indolent presentation. In our case, unfortunately, this patient didn't have proper follow-up from a PCP. We don't know if she had previously feeling clinical signs of waxing and waning, enlarged lymph nodes, and unfortunately, she presented with this chylothorax. So it's not the most common presentation for diagnosis of low-grade follicular lymphoma. I don't know if there's any questions or.
Thank you, Dr. Tokashiki, for excellent presentation. As for now, we don't have questions from audience, but I have several questions about the procedural part of the case. If you can kind of tell us about the. So you said that there was a chest tube placed. Was it like a large bore or a pigtail? What size was the chest tube? So does it matter? I'm trying to see how was that managed.
Yeah, I don't have the exact, I don't remember how many, I don't have that size of the chest tube.
Yeah, it looks
but
like,
I believe from what I
small size, yes.
Small.
Yeah, and how long the chest tube stayed there? 6 days?
6 days. 6 days.
Okay, and I believe at that time the drainage reduced, and that was the like made decision that it needs to be removed, or it was still draining.
No, the drainage stopped at the day 1 was 1.5, and the consecutive days were like less than 1 liter. So it was a low output.
Okay, okay. And this case has a unique kind of presentation. I just wanna, I have a question about the left side. I'm just wondering if the left side was sampled or not. We know that there was a right thoracentesis and there's a chest replacement. How about that, I think, small moderate side of the left effusion? Was it sampled or not?
It was not sampled. We attributed to the lymphoma that was diagnosed, and probably because of the mediastinal enlarged lymph nodes, we had a higher obstruction of the thoracic duct. So that's why the patient presented with bilateral chylothorax, but it was not sampled.
Oh, okay. So it'd be interesting to know if that was bilateral chylothorax, because it's pretty unusual, I think, to have bilateral chylothorax. It would be very interesting, yes, because it will be kind of multi-level involvement of the thoracic duct. But I would say if I was kind of wondering what else I would do in this case, I would sample the left side out of curiosity to see if it's a chylous effusion or something else. But that's interesting if this was assumed to be bilateral chylothorax. And one question about the cytology of that effusion. Was it showing anything, cytology or flow?
Cytology, no. It was a negative for malignant cells.
Okay, yeah, that's not unusual to have that. Okay, I think I exhausted my questions. Again, it was a very nice case. I think chylothorax is hard to manage. It's always challenging, and I would say the management is the challenging part, because when you sample the effusion, you get that milky kind of like effusion. There's several things can happen. Yes, one is like infection. Is this like a purulent empyema, or this is just a chylothorax? Yes, I think that's one thing that you need to know, kind of comes to your mind when you get that color when you sample the effusion. But the management is challenging, and you went through all the management options, and it was very thorough, and thank you for that. And of course, the conservative management is the most important, and also you need to treat the cause. Yes, and in this case, it was lymphoma. And is there any follow-up with this patient? After you mentioned there was a 3 months follow-up CAT scan, is she coming back to the clinic? And I'm just wondering how is she doing now?
Yes. So last time we saw her was around April of this year, and that was a repeated chest CT. So after being on rituximab, we saw also improvement of the left-sided effusion. So that was reassuring. That most likely was due to the lymphoma, and there was no need to do another sample from the left side.
Yeah, I would say if she's going to come back in the future with, again, the persistent left diffusion, I would sample the left side. That's going to be really interesting. That's going to kind of go back and answer your question, your team's assumption that this is bilateral chylo, or it was a unilateral and separate kind of different left-sided diffusion. That's going to be interesting. Okay, thank you very much, Dr. Tokashiki. Thank you for excellent presentation. And I would like to encourage everyone, the fellows, pulmonary critical care fellows, to submit the case reports, and we are going to be happy to moderate. And I just want to remind that all the case presentation in the fellows corner gets recorded, and it's going to be in the Society of Advanced Bronchoscopy website. And I think this is a good experience for us and for the fellows, and this is another kind of opportunity to present good cases and have a good discussion. Thank you very much.
Yeah, no, thank you, Dr. Kashishin. And I wanted to share a picture of my hometown in Lima, Peru.
Okay, thank you. Thank you.
Thank you.
Thank you everyone for joining. Have a good evening.
Have a good evening. Thank you.
Have a good evening.